colleagues at the Institute of Medicine on a very giant screen. So my big figure is there towering over shop and all of you. So that makes me feel good. The comments that you made, let me pause. Sheila, can you still hear me okay?
We can. You're a little bit faint, but we're paying rapt attention.
Okay. I'll speak loudly and keep my comments very minimal and then leave it for questions. And thanks to our chair and also many thanks for the invitation to join you. It's not only the Ebola response that keeps me here, but I've been asked to lead the WHO's work on health systems recovery post-Ebola. And in addition, it is WHO executive board meeting this week, so all the staff are in town working with ministries. So all of those conspire to keep me here in Geneva. Let's make perhaps key points and then some ideas on the future, because I think our previous, both Enrique, also our other panel members have made excellent points about the service delivery improvement and issues on bundles of care and measurement. But one of the points that Enrique highlighted is the possibility of reaching the quality in light of the major push that we have on universal health coverage these days. And I would encourage us that we have had in this universal health coverage agenda something of an error of linear thinking, that first we need to create access to care, and that is the primary to get people in the door, and then we need to worry about the quality of services. And obviously that's not the way to create sustainable health systems. So issues in many of the countries we see, particularly low-income countries, I would argue, and Enrique was exactly right to note the differences between the different parts of between low and middle income and upper middle income countries. But particularly in low income countries is the automatic escalation of services of very poor perceived primary care. So you automatically have much higher patients than normally expect at secondary and tertiary hospitals, precisely because the quality of services in primary care is deemed to be so poor. Now, the push we have had within WHO has been to look at quality, sort of the new iteration of universal health coverage. The exact packaging of that is based on a quality agenda. We started with a number of people working in the room, an initiative on universal health coverage and quality. But I think one of the points we should be honest with ourselves about is the fact that within health system strengthening, and this workshop being so well brought together there in Washington as part of a large effort by USAID and US to examine their approaches on health system strengthening. Just as we have criticized our partners in tuberculosis, HIV/AIDS, malaria, and child health occasionally, although we're more friendly with them, for being too vertical, health systems have also been that way. Rarely, very rarely, do you find health financing people working side by side with the service delivery and quality, working side by side with the health workforce individuals. And as we know, as our previous speakers have pointed out, all of these agendas, the skill mix and distribution of staff, motivations, and incentives are integral to delivering quality of care services. And I would also argue perhaps that even this workshop itself highlights tendencies in certain communities to the people that already believe the agendas that we have. So obviously, when you're talking about quality of care, you bring the world's experts on quality of care. And I think a next step for USAID, IOM, and other partners in the movement to look at a follow-up workshop that would speak only to our colleagues working at the World Bank on macro policies, ministers of finance, etc. To me, has never been clearer than the work we have had to do in the Ebola-affected region on rebuilding systems. And this brings me to my final point before closing, which is that the effort that has existed there has brought together a host of actors looking at different elements of health. Very difficult to our Ministry of Health colleagues to engage actively in the dialogue about how safe, high-quality health services are center of their long-term health plan. But even that we need to make the argument that this is at the center for these countries' long-term economic development. Health and sustainable health system is an economic driver, workforce employer in many countries, particularly the affected countries. And these types of outbreaks are huge economic impact on the country. One of the things we've also not done a good job is linked to other agendas, and just listing a few. There's a major agenda around director, as some of the room know, of for the U.S. government working at the Agency for Healthcare Research and Quality, the U.S. Healthcare Quality Report, National Healthcare Disparities Report, and worked quite a bit with Steve Clausinger and others on indicators for that and quality indicators. But I was with a number of international colleagues at one point, and someone asked me, well, why does the U.S. a disparities report at the same time as the quality report? And I tried to explain the reasoning that we took the quality indicators by different socioeconomic, education concerns, etc., and was told that the America really was one of the countries that was overly fixated on this, and it wasn't one of these agendas for necessarily the developing world. But I think that we need to begin to look at quality varies across the different at-risk groups. The security and disease surveillance agenda is one that offers a very ripe and productive possibilities for the quality discussion to advance health systems. We do not have a health system that supports the international health regulations and kind of disease, reportable disease agenda, and a second health system that does all the other stuff, like care, hospitals, etc. One system is the same workforce that we need to link these back up. And finally would be a hard look at the non-communicable disease action plan at the highest level, and working in those indicators around performance on non-communicable disease, national and international dashboards. There's been the recent effort at rationalizing indicators, both as part of the MDG agenda, but there's also a set of 104 indicators published by WHO colleagues. And while there are service delivery in there are no, in my mind, true quality of care indicators in there. In large part because we haven't pushed far enough at a level for sustainable measurement systems that can really report across countries. And that is one area that we need. And finally, I guess my plea would be that we need to look at this question in terms of patient-centeredness and care integration. And we came to this. It's easily the area of development, this concept of patient-centeredness and responsiveness. For the World WHO included responsiveness is still measured satisfaction, which is at least a decade, if not 2 decades, out of date with current scientific thinking. But we haven't systematically moved it into our projects and into our reporting mechanisms in terms of how to report that reliably and in a meaningful way. WHO will continue to work on these types of areas, continue to have international campaigns on safety. We have work on the multi-professional curricula, which I think stream is another great solution area. But the idea of developing an agenda that engages the private sector, as was mentioned, that looks at education in terms of being able to build a workforce that understands quality, and then also continues to push the agenda on targeted interventions that work, I think will be a key element. So many, many thanks for your patience. I hope change through.
Thanks. Thanks very much, Ed, and thanks for bearing with our technological difficulties. It's probably more painful for you than for us because at least you could hear us, and we couldn't hear you. But hopefully we can come back to you with some questions. So please don't go away.